Good morning and welcome, everyone. Thank you for joining this Knockout Opioid Abuse Day Learning Series webinar, Opioid Use and Misuse Among Older Adults. Thank you all for joining us, all of you who have joined us throughout the year, and also a special welcome to those of you who are joining us for the first time that we met at last month's RX and Illicit Drug Summit. So thank you for joining us. Some housekeeping items. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for one EMT elective CEU. The Partnership for a Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic directors. And this program is eligible for a maximum of one Category 1A hour or continuing education unit. PA Planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon and Johnson & Johnson, and all other panelists, faculty, and reviewers have no relevant financial relationships to disclose. All relevant financial relationships have been mitigated. If you wish to claim CME or CE credit, you must do so within 30 days from today's date. After that, we'll no longer be able to issue you credit. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the New Jersey Office of Alternative and Community Responses, the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And I thank them all for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. And I'm so pleased to welcome today's expert faculty. We have Dr. Abelish Desai, who is medical director of the Idaho Memory and Aging Center. He's a board-certified geriatric psychiatrist, medical director of the Idaho Memory and Aging Center, and clinical associate professor in the Department of Psychiatry and Behavioral Sciences at University of Washington School of Medicine, Idaho Track. We also have with us Dr. Donna Lisi. Donna is an independent consultant clinical pharmacist. She holds board certifications in pharmacotherapy, geriatric pharmacy, psychiatric pharmacy, and ambulatory care pharmacy. And she has status in the American Society of Consultant Pharmacists and the American Academy of Psychiatric Pharmacists. And so we're so pleased to hear from our expert panelists today. And Dr. Lisi, I'm going to turn the presentation over to you.
Thank you so much, Angela, and thank you for the Partnership for Drug-Free New Jersey for having me today. It's an honor to be presenting today with Dr. Desai. This is a blog post that I wrote about a year ago, which called attention to this overdose deaths in older New Jersey adults that we're seeing. And so I'm so happy that this has given the presentation that we're giving today to highlight this even further. Next slide, please. So to start out with, I'm going to go over my learning objectives. The first is to describe the waves of the opiate epidemic and its manifestations in the older adult population, to identify opiate use and overdose patterns in New Jersey among older adults, to list factors that increase opiate use and misuse in older adults, and lastly, to enlist community partners to minimize risk associated with opiate use and misuse in older adults. Next slide, please. So no discussion about the opiate epidemic would be complete without a slide of the history of the opiate epidemic. So the first wave that we see here, and this describes the 4 waves, is when we saw an increase in prescription opioids, and that was basically in the early 2000s, late 1990s. The next wave, when we started reining in the use of prescription opioids, we started seeing an increase in heroin. That was followed by the next wave, which was an increase in fentanyl. And the wave that we're currently in, the 4th wave, is now we're seeing a combination of fentanyl and psychostimulants. Next slide, please. So the older adult population has not been spared the overdoses that we're seeing in the general population. This is a slide of age-adjusted drug overdose death rates from adults age 65 and over between the years of 2000 and 2020. And you could see that just as we've seen the opiate epidemic occur in the general population, in the older adult population too, we've seen an increase in that age group as well. Next slide, please. Between 2022 and 2023, the rate of drug overdose deaths increased among adults aged 55 to 64, as well as age 65 to and older. When you look at the literature when it comes to substance use in older adults, there are many age brackets that they use. 55 plus is one of the most common ones, and so here my talk here will refer to anyone 55 plus as an older adult. From 2022 to 2023, those age 65 and older actually had the largest percentage increase in the rate of drug overdose deaths. Next slide, please. So I just want to shift gears, and that was national data that I presented. So now I want to look at opiate use and overdose patterns in New Jersey among older adults. Next slide, please. This is a very, if you're not familiar with this, this is a wealth of information. It's the New Jersey Overdose Data Dashboard. And the orange box shows you all the different types of information that you can obtain from this website. Next slide, please. So some of this data, the data that I'll be presenting comes from that website. This is data from New Jersey SORTers, which is the state unintentional drug overdose reporting system, overdose mortality data from 2023, which is the last year that data is available. When you look at this slide, you'll see that it has very nice information on here because it highlights the drugs and the substances of abuse on the left-hand side. On the right-hand side, we see a breakdown by age. And if you look at the age brackets, it says 55 to 64 and then 65 plus. If you add those two groups up, you'll see how much how high that rate is compared to the other groups as well. And then in the middle is the map that shows you some of the hotspots that still were present as of 2023. Next slide, please. So this is data from the medical examiner's office, and this again is found on the overdose dashboard. This is data from April 21st to April 27th. If you pan down to the bottom of the slide and you see the different age brackets, you'll see that 65 to 74 there were 4 deaths. 55 to 64 there were 6 deaths. So if you total that, that's a total of 10 deaths just within that 1 week period, or suspected deaths, I should say, that out of 25 deaths. So about 40% of those age 55 plus accounted for the suspected deaths during that 1 week period. Next slide, please. This is data, the same data, but looking at it from January 1st to that cutoff point of April 26th. And again, here now we're seeing some suspected overdoses in 75 to 84, and then 85 plus. If you added everything 55 plus and over, again, that turns out to be about 38%. So 38 to 40% of suspected overdoses are in those age 55 plus. Next slide, please. And this is occurring at the same time that opiate prescription rates per 100 residents are decreasing. This is data from 2012 to 2024. And you can see the sharp decrease. And this is thanks to webinars like this and all the efforts of those in the community who are helping to decrease inappropriate opiate use. Next slide, please. This is information also from the database, from the opioid overdose database. And this is drug-related hospital visits for non-fatal overdoses. This is the first year that data was available, and this is 2010. You could see at that point in 2010, the whole state was lighting up for the most part. Anything that's bright orange, bright red, that was hot pockets of overdose, of non-fatal overdoses. I want to call your attention to the left-hand side, to the right-hand side, the statewide age-specific rates per 100,000 residents, and this is data on opioids only. If you look down towards the bottom of the slide, you'll see that those age 55 and plus, the 55 plus, 55 to 64, 65 to 74 and 75 to 75 and older, that those were the lowest ranking groups for the statewide age specific rates of opiate use. And I'll show you how that changes over time. Next slide, please. So now we now moved forward 10 years. This is now 2020, and for the most part, we've done a good job in decreasing these non-fatal overdose visits. Much of the state has now become lighter shade, which is a good thing. We also see, if you look at the right-hand side again, that the 55 plus age group is all at the bottom, which means that they have the lower rate for age-specific rates of overdoses, of non-fatal overdoses with opioids. Next slide, please. So rather than continue on with every slide like that, I did do a summary slide. What we just saw was the 2020 data, and the 55 plus, 55 to 64 was ranked number 4. We could see the other groups are also at the bottom of the ranking. The age of average naloxone deployment by EMS or law enforcement was 43 in 2020. In 2021, now the 55 to 64 age group moves up to number 2 in ranks. And we also see the age of the naloxone deployment increasing to 45. 2022, just 1 year difference. Now the age 55 to 64 age group is number 1 when it comes to drug-related hospital visits for non-fatal overdose deaths. And the age of the naloxone deployment has increased to 47. The age 55 to 64 group kept that ranking in 2023, which is the last year that we have data for. They still remain number 1, and the age of naloxone deployment remained at 47. In 2024, the statewide data is not available yet. The data for the naloxone deployment is that increased to 48. And for the first 2 months of this year, the average age of naloxone deployment broke the 50th decade. And so age 50 was what we saw as the average age for EMS and law enforcement deployment of naloxone. Next slide, please. So this is just showing you what we just presented and showing you how more of the state became lighter in terms of a yellowish color. And here you can see what I was talking about, how the 55 to 64 age group moved up in ranks. They are now up in on the right hand side. They're up in the top corner, which demonstrates that they are the first main group for age specific rate of opiate non-fatal overdoses that result in a hospital visit. Next slide, please. So we talked about how opiate use has decreased, and we saw that sharp drop. But if we take an age-specific look, and the blue bar is 55 to 64, the red bar is 65 to 74, the gray bar is 75 to 84, and the orange bar is 85 plus, you can see that the 55 to 64 age group was increasing, and it's pretty much seemed to have plateaued and slightly decreased. But the 65 age group is still increasing, as is the 75 to 84. So this is something, as prescription opiate use has decreased in the other age groups and the younger population, it's still now the older age group is accounting for more of that use, and that use has not decreased that much. Next slide. I also serve on the Somerset County Overdose Fatality Review. I want to thank my colleagues, Lillian Alexander and Dr. Corey Morton with Rutgers Center for Preventive Science. They do the data analysis for our group. This is data looking at the decedents age 55 plus. We had 113 decedents whose cases we reviewed, of which 28% were age 55 plus. And here you can see the male and female breakdown. 73% were male, about 27% were female. And that actually, the female group was actually higher than what you would see the percentage for females for the overall overdose decedent population. Next slide, please. This gives you a breakdown of the toxicology reports of those who had passed. And so even in this age group, fentanyl is number 1. We see 4-AMPP, which is a metabolite, norfentanyl, which is also a metabolite, that those were the main substances that were found during the autopsy reports. The second most common is cocaine. And as I mentioned, we're in that 4th wave, which is the psychostimulants and the opioids. And this data confirms that. Next slide, please. So just as I mentioned that we're seeing an increase in stimulants, this is also data from the overdose dashboard. And this is the first time in 2022 that this is data on stimulants. And if you look at the right-hand side, 55 to 64 was number 1 in 2022. Next slide, please. And this is data, the same type of data for benzodiazepines. And here we see in 2019, age 55 to 64 was number 1. And here we see at that point, most of the state was lighting up as having high rates of drug-related hospital visits for non-fatal overdoses associated with benzos. Next slide, please. So I just want to shift gears once again and look at factors that increase opiate use and misuse in older adults. Next slide. So there are many factors that contribute to this issue. There are multiple comorbidities in older adults that associate with pain, such as arthritis and cancer. There can be surgical procedures that also are used to address arthritis, knee replacements, hip replacements, as well as cancer surgery, and surgeries for other things as well. There are multiple medications that can interact with opioids, benzodiazepines, gabapentin, sedating antihistamines. These can all can potentiate the effects of opioids. There's increased sensitivity to opioids due to pharmacokinetic and pharmacodynamic changes. It can be cognitive impairment that can lead to overuse. The older adult might forget that they took their opioid and take another dose. And there's underlying respiratory disease, COPD and asthma, that increase the risk of respiratory depression. Next slide, please. Other factors include a history of substance use to other substances. And as this might have started out to medicate physical pain, we also see that the use might continue to medicate existential pain or depression or anxiety, isolation and loneliness, all psychosocial issues that we need to address as a society. There can be unsafe medication practices, sharing medications with friends and family, as well as inappropriate prescribing of opioids or appropriate, what started out as appropriate, but then it was continued too long. There can be failure to try other medications first, going to the opioid first instead of trying something else, and then failure of the other medications that we did try instead of an opioid. And then lastly on this slide is either doctor or pharmacy shopping and buying medications online. Next slide, please. So this was an article that was published in 2016 in the Journal of the American Geriatric Society, and it looked at high-risk attainment of prescription drugs by older adults in New Jersey. So that's why I thought it was important to include this slide. About 15% of the population that was surveyed, and this was folks aged 60 and plus, a requirement was that they had to have a phone, cell phone, landline. And they looked at when they did the survey, how many people admitted to having high risk attainment, meaning that they got opioids by a non-legitimate source. And of that, 15% of the population stated that they did this. And the number one way was going to multiple doctors for the same prescriptions. The number two way was also stealing from doctor's office, from hospitals, from pharmacies. And what was interesting is that the oldest age group had a higher risk for doing that than the 65 to 74 age group. So that was an interesting finding that the authors called out. I found this article so interesting that I actually wrote a letter to the editor, and it was published in that you can see on the bottom of that slide. Next slide, please. So and I'm not going to go into great depth about this because it's kind of not the scope of this presentation, but as we talk about cutting back on opioid use or trying to use opiates more appropriately, some patients or some older adults might switch to using cannabis. And I just want to put out more of an alert and things to look for. So the first study was a study that came out of Canada, and it looked at two waves. The first wave when they approved the dry flower cannabis, and then the second wave was after they approved cannabis edibles. And with each wave of cannabis approvals, they saw an increase in the number of older adults who visited the emergency room for toxicity. We saw the same thing in California. The second reference there, and the citations are on the bottom of the slide in the blue bar. Here we saw this in California in that we saw that there was an increase over 1,800% following the approval of recreational marijuana, and these were for cannabis-related ED visits. In both cases, they were for cannabis-related ED visits. An article just came out by Myron et al. That looked at people who ended up in the emergency room for a cannabis-related hospitalization or for an ED visit. When they followed them out for 5 years, they had a higher risk of developing dementia. So that was something that was just some new information. And then lastly on this slide, there's about 400 drugs that are known to interact with cannabis. And of these, about 28 are major. There on the right-hand side of the slide is a wonderful app that was developed by Penn State College of Medicine. It's called Candor. And this is a website-based application where you can search for drug interactions for THC and CBD. Next slide, please. That app is free, I should say. This is a slide that I just want to highlight. This was an infamous case, I should say, of the blackout brownie. This was a case of a 65-year-old woman who was taking morphine for pain, for chronic pain. It wasn't cutting it, so her son gave her a brownie. The brownie contained 1,000 milligrams of THC. It was the equivalent of 20 servings. Her husband and her shared the brownie. He got nauseous and went to bed. She ended up collapsing and dying, and was found the next morning by her husband at the foot of the stairs. The autopsy results revealed that she had severe cardiovascular disease, atherosclerotic disease, as well as a severely elevated THC level. And so more data is coming to light about the cardiovascular effects of cannabis. And I just want to call that out because we have an older adult population that might have either known cardiovascular disease or cardiovascular disease. And this was a statement on the right-hand side of the slide from the American Heart Association, their scientific statement on medical marijuana, recreational cannabis, and cardiovascular health, where they call attention to this. Next slide, please. I want to shift gears once again and talk about fake pills, not counterfeit pills, but fake pills. Counterfeit pills imply that the drug could still be in there, it's just from a not a legitimate source. In this case, fake pills are pills that may not contain any of the substances that it says that they contain. So on the right hand, I have one, and on the left hand, I have another. One is real and one is fake. If you want to, feel free to put into the chat if you think the right or left side is real or fake. And this is just informal, so we're not going to really do this as a poll. There's a QR code on this slide. If you scan that QR code, it brings you to the DEA website that's listed on this slide. And then also another great organization is Safe Medication, safemedication.org. And this slide will send you a weekly newsletter of any things like this, counterfeit pills, whether it was counterfeit Ozempic or counterfeit fentanyl or any other type of drug. It gives you information about that. In October 7th, 2024, the DEA warning that dozens of fake online pharmacies sold millions of fake pills to customers in all 50 states. So New Jersey was affected. Next slide, please. So how many guessed right? So on the left-hand side is the real oxycodone 30 milligrams, and on the right-hand side is the fake. The fake looks so perfect, and the real looks so disheveled or chiseled away. And so it's very easy to see how an unsuspecting customer or patient could easily be fooled by this. Next slide, please. And those pills contain fentanyl and methamphetamine, no oxycodone. Okay, I want to shift gears once again. What older adults say healthcare providers talk to when they prescribe opiate medications, and this is information from the University of Michigan. About 90% said how often to take it, 60% about side effects, 59% about when to reduce the amount, 48% risk of addiction, which is usually a large concern in an older adult population, and then 43 talked about risk of overdose. To me, that number is too low, and 37% talked about what to do with leftover pills. So these last two items I want to take a deeper dive in. Next slide, please. So one of the things that we have to do is to destigmatize naloxone among older adults. I've given talks at senior centers and I've passed out naloxone, and there's always one person in the audience who goes, "No, that's not me. I don't abuse drugs. I am not," air quotes, "an addict," a term that I don't use, but that they use. And so this is something that we really have to work on destigmatizing it. Have that talk. A change in medication, a change in organ function, drinks with friends. Any of these can lead to unintentional overdoses, and that's something that's very important. Older adults should know the signs of an opiate overdose. If a spouse is on chronic opioids for chronic pain, they should know how to recognize signs. They should know how to use naloxone. And that's the bottom little pink box shows that from naloxone.com that oftentimes there are other people in the house when someone has a fatal overdose. So knowing that and having that conversation can save a life. Next slide, please. What older adults did with their leftover medications. 86% saved them for later. This is how we share them with friends and family inappropriately, or they end up getting discarded in the garbage later on. 13% returned them to approved locations, which was a great thing. Police stations or pharmacies are approved locations, and I'll talk about that in a minute. And the 9% threw them in the trash or flushed them down the toilet. Throwing them in the trash is a big problem for diversion, for access to pets and wildlife. So that's definitely a no-no. And that's also information from the University of Michigan. Next slide, please. This is something that just came out about this year in March of 31st. So there's new prepaid drug mailback envelopes that are available for safe disposal. Pharmacies can access this. I have the link downstairs, down the bottom of the slide. This is part of the opiate analgesic risk excuse me, allergies are kicking in. This is part of the FDA opioid analgesic risk and evaluation mitigation strategies program. And so their pharmacies can get free mail-back bags that will go back to the manufacturer for them to destroy the drug. I also want to call out the DEA National Take Back Day. We just had a Take Back Day on April 26th, and I'll mention one of my community partners that I mentioned in a minute helped us distribute naloxone at that event. The next one will be in October, and is a great way to get rid of old and and unused medications. Next slide, please. So we talked about reining in the use of opioids, but I also want to talk about the pendulum that may be swinging too far in the other direction. This is an article, and the QR code's there. You can scan it and get the full text article on trends in outpatient opioid prescriptions for cancer pain between 2016 and 2021. And what they found is that there was a five-fold decline in opiate doses prescribed by oncologists, which raises the concern of whether or not cancer pain is being undertreated. Next slide, please. Again, I want to shift gears, and now I want to talk about community partners that help minimize the risk associated with opiate use and misuse in older adults. Next slide, please. So this is a program in New Jersey. For those who aren't familiar with it, is Naloxone 365. Pharmacies throughout the state can sign up with this program. It's run out of Trenton, and what they do is they agree to dispense or give anyone 14 and older who comes into the pharmacy. They agree to give naloxone if the person wants it, anonymously to anyone 14 and older, and then the pharmacy gets reimbursed from the state. About 690 pharmacies throughout the state have already signed on for this program, and we really like to see even more get involved with this. Next slide, please. This is a new initiative in Somerset County, which is where I reside and where I do my volunteer work. This is something that we just started this year. Because of the concern about this increase in overdose deaths in older adults, I want to give a shout out to Lisa Federico and Ebony Torres. Ebony Torres is leading this project right now, and it's a great initiative. Substance awareness and guidance for the elders, and Ebony came out with the inspirational name of SAGE. This is a prevention collaborative, and the goal is to share targeted prevention strategies that raise awareness, educate, and provide resources for older adults to reduce the risk of substance use and its associated harm, while fostering a supportive, informed community that promotes healthy aging and well-being. We meet monthly, and we are brainstorming a lot of issues that can help our community. Next slide, please. This is another community partner. This is Prevention Resources. The bench that you see there was handcrafted. It has a sign out that says this probably isn't your best option. The bench is constructed so that if you sit on it, you'll slide off. It's not designed to be sat on. It's designed to call attention to the fact that while this might look pretty, it's not necessarily your best option. And so too opioids might not be. And if you scan that QR code, it will bring you to a list of resources for non-opiate options for pain. That bench sat at our township senior center for a month. And while that bench was there, I held an opiate education workshop where I discussed opiate use. I discussed alternatives to opioids, as well as safe medication use, and distributed naloxone at the end of the session. Next slide, please. This is another great partner of ours, Community in Crisis. They hold a pop-up, a peer recovery pop-up once a month. These are folks that have lived experience, so they really can relate to those who are struggling right now. They also have an alternative approaches to pain management course that they offer to help people choose options other than opioids. Next slide, please. This is a list of resources. The WISE program is something that we're using more and more in our county. We're trying to incorporate this even in our next grant cycle for our municipal alliance. It's an evidence-based program for older adults that educates on making healthy choices and avoiding medications. It's a 6-session period or a program in which one session's on medication use and one is on substance use and addiction. And then the other references I have on here are age specific to the older adult population and are from several federal sites, which are very trusted sources of information on this topic. Next slide, please. So before I pass the torch, I had a sneak peek at Dr. Desai's presentation. I'm really looking forward to that. I know he's going to be touching on prevention, early diagnosis, and treatment, and I just want to give a pharmacist spin on some of those. So this is really kind of in its infancy, the emerging role of pharmacogenomics and epigenomics in opiate use and opiate use disorder. I have a number of genes and the potential impact. Some of this data is very limited. It's very preliminary, but I do want to mention that, as is the epigenomic data. I also want to mention that back in 2016, the National Action Plan for Adverse Drug Prevention highlighted the 3 main classes of drugs that were associated with adverse events, and of those were opioids, in particular respiratory depression from unintentional overdose. I also want to mention that for early diagnosis, it's really important, especially in an older adult population, to be aware that other drugs that a patient may be on, other medications, may mimic some signs that we may see. So constipation can occur from calcium channel blockers. We can have dizziness or drowsiness from antihistamines, things that might be attributed to other medications that really are due to opioids. And then lastly, I want to mention here for treatment, there was an FDA safety communication that was issued in January of 2022 for transmucosal buprenorphine and dental issues, an increased risk of dental cavities and tooth loss. And that is by no way a reason not to use this very effective medication. It's just a call to action that before someone's placed on these drugs, that they should be seen by a dentist to get some baseline data and evaluation of their health. Lastly, was methadone, and just that methadone is a great drug for both pain and for substance for MOUD, but it is associated with major drug interactions. And with that, I want to next slide, and I want to pass the torch and thank you for your attention.
Thanks so much, Dr. Lacey. And Dr. Desai, we will now turn the presentation over to you. Welcome.
Thanks, Angela. Hi, everyone. Namaste. Opioid use disorder in older adults. Next slide. So one of the resources I would recommend is the book I wrote with Dr. George Grossberg. And the other is with my wife. I'm big into mindfulness. Next slide. So the learning objectives are to summarize how to assess risk factors for opioid use disorder in older adults. Dr. Lissy talked about some of them. Explain how the care team can mitigate risks among older adults when prescribing opioids. Again, Dr. Lissy mentioned many of this, and summarize how to treat opioid use disorder in older adults. Next slide. So for older adults, there is a double stigma. One is addiction itself, if you have addiction, and then second is ageism. This is my own personal opinion. I'm from India. Aging is a privilege. Growing old is not a disease to be cured or defeated, but a privilege, tremendous privilege to be humbled by, to be grateful for. A privilege withheld from most of our ancestors and so many of our brothers and sisters. Let's become worthy of becoming old by falling in love easily, holding our heart gently, holding our fears lightly, and forgiving continuously. Next slide. So the first focuses on risk factors for both opioid misuse and opioid use disorder. So one is to regularly use opioid risk tool. It's not really validated in older adults with high quality studies, but it's still worthwhile. So if I'm prescribing opioids, it'll be good for me to know what the score is. Again, avoid prescription of opioids for acute pain longer than usual. Prescribing opioids for chronic non-cancer pain in individuals with 4 or more score of on the ORT, there is a higher risk of opioid misuse and opioid use disorder. Next slide. Again, if we use too high a dose of opioids or for too long, if there is history of significant childhood trauma, if they have significant post-traumatic stress disorder or other trauma-related scores on validated screening tools, then again, they are at higher risk of opioid misuse and opioid use disorder. Next slide. Again, it depends on what social biome the person is in, and then social determinants of health. I'll share a case over here. One of my patients, age 77, male, he himself is a counselor in addiction, and he has history of, quote, going hard, end of quote, on drugs when he relapses. So he has episodic addiction, but we have reviewed there is no history of major depressive disorder, recurrent or bipolar. And he has done great on buprenorphine for 5 years. And then we decided he felt, let's take it off. So he was tapered off 6 months ago. He was still doing well, but then developed significant medical issues. He needed neck surgery in 3 weeks. He's in severe pain now for a month. And now he was put back on buprenorphine, 24 milligrams, says that it doesn't help. So then he wanted to try morphine extended release, 30 milligrams 3 times a day. Canadian guidelines on opioid use disorder recommend that as a second line agent after buprenorphine and methadone. Initially, he said it worked, then he said it doesn't work. Then he wanted to go on oxycodone, 10 milligrams every 4 hours, and he was taking 7 pills a day. And again, the primary care physician was worried about overdose death appropriately, no diversion concerns. So the PCP consulted a superb geriatrician and addiction fellowship director over here, Dr. Todd Palmer. And then I happened to be there, and we came up with these recommendations to add duloxetine for chronic pain management, topical diclofenac. We declined naproxen. We thought about celecoxib, did not prescribe it. We declined methadone because of what Dr. Lissi had mentioned, drug-drug interaction risk, prolonged QTC interval. We considered anticonvulsants, gabapentinoids. We recommended cognitive behavioral therapy for pain. We know a great pain psychologist right here in our team. By the way, all this was done through collaborative care via telemedicine. So that's another good thing to remember. And then we decided to increase the buprenorphine. So in certain situations, high dose buprenorphine, dose above 24 milligrams, may be appropriate and necessary. And this patient had a lot of these risk factors. Next slide. So access to opioids obviously is another risk factor. Conduct disorder in childhood is another risk factor. For more details, I would recommend reading this article that I wrote with my team. It's a very good review. Next slide. The next learning objective is to explain how we can mitigate the risks in older adults when prescribing opioids. Next slide. So again, we are, as Dr. Lissi mentioned, we are constantly pulling these people out, but we need to figure out a way that they don't get into the overdose world and then have to go to the emergency department and in the hospital. Next slide. And again, we have to approach this with strategies and tactics. Strategy without tactics is the slowest route to recovery, according to Sun Tzu. And tactics without strategy is the noise before defeat. Next slide. So to me, the key prevention strategies for all age groups, but especially in older adults, would be to enhance access to virtual treatment. By the way, 95% of what I do now is virtual, collaborative geriatric psychiatric care via telemedicine. Expand access to opioid use disorder. This means even if you don't have insurance, you have access. You can relate to that in, say, prison population. Increase education on naloxone, which Dr. Lissi mentioned. Next slide. Again, early diagnosis is very important. Having good screening tools is very important. Lots and lots of education about opioid prescribing directly to the older adult community and their family, but also to primary care providers, physicians, advanced practice providers, and other prescribers, including psychologists now. Some of them can prescribe. And again, a lot of times if we treat comorbid conditions, then we can actually reduce opioid overdose because they won't start self-medicating by taking higher opioids or using other drugs that are very sedating, like trazodone. Next slide. Again, please check out this chapter in our book. Rational deprescribing is now a whole set of clinical skills itself. And a large chunk of my practice is rational deprescribing of many medications, especially the medications like gabapentin, pregabalin, hydroxyzine, trazodone, and many other sedating drugs. Let me share another case here. We are seeing opioid misuse and opioid use disorder even in nursing homes now. This is a 72-year-old female. She has achieved great success in terms of not using methamphetamine for 28 years. She had that addiction in the past. She has a history of opioid use disorder. She's on methadone 10 milligrams twice a day. She has rheumatoid arthritis, osteoarthritis, neuropathic pain. She has bipolar disorder. She feels that this methadone is not working and she wants oxycodone 10 milligrams 3 times a day. When we talked about buprenorphine, she said that it causes migraines. Uh, uh, she's on duloxetine. She says it's not working. She's on very high dose of gabapentin, 1,200 milligrams 3 times a day. So again, with close collaboration with primary care, the pharmacist, and myself, we switched to oxycodone 10 milligrams 3 times a day with the understanding that she will not be getting more. And if we are going in the wrong direction, we may have to switch back to methadone or buprenorphine. We tapered and discontinued duloxetine, switched gabapentin to pregabalin. Pregabalin is approved in Europe for anxiety disorders. She has been having a lot of anxiety. Thinking was that it might better treat her anxiety. She also started cognitive behavior therapy for pain with our psychologist, online church, gratitude journaling, relaxation exercises with free high quality apps like UCLA Mindful, staff and family education. She had 2 sons, one lot of conflicts, the other was very supportive, but he needed a lot of education about addiction. And then address conflicts with the son, physical therapy. So this is another example of how we can do these things to prevent overdose deaths in clinical everyday care. Next slide. Again, as I mentioned, if we can really focus on not giving opioids for long-term treatment of chronic non-cancer pain, we'll be doing a lot of good. I've sent a rough and tumble PDF ebook that my wife, she's a psychologist, and I wrote to Matt. It should be available on the website as a resource. But that's another area where I have very focused practice, is how to improve chronic pain, at least function-wise, without the use of opioids. Next slide. Again, the tactics. So now we have strategy, which is to avoid opioids. How do you actually do it? Through collaborative care. So again, in geriatrics, we talk about time, team, and training. So we have to constantly do that, train each other. Next slide. Again, the first case, he himself does a lot of pain management program education with other people with opioid use disorder and chronic pain in young as well as older populations. So that's another great tactic. It's better that they say it than I say it about how to manage pain. Next slide. Again, if we had to treat, it's better to go very systematically through all these steps. So I'm not saying never to use opioids, but I think this is my personal opinion, 95% of the time we can avoid opioids or use it for very short term or PRN. I include tramadol in opioids also. In that ebook, there is a whole section on tramadol. Anyway, we need to focus on non-pharmacological interventions, topical analgesics, certain antidepressants, and selective judicious use of gabapentin or pregabalin and interventional pain management before we go through more risky drugs. Next slide. So again, we have to routinely use physical therapy, exercise therapy, CBT for pain, mindfulness-based interventions for all patients that we are managing chronic pain. Next slide. Third learning objective is to summarize how to treat opioid use disorder in older adults. There are some differences. So let's go through them. Next slide. So again, we have now several validated tools that we should use routinely. In that second case, the nursing home patient, it was the physician assistant I worked with very closely who went to the prescription drug monitoring program and saw how she was trying to obtain opioids from different primary care providers before she came to the nursing home. And again, this is what Dr. Lissy mentioned happens. And he was able to then accurately diagnose opioid use disorder. In some other cases, family and uh, friends are crucial in appropriate diagnosis. I have a 74-year-old patient admitted into the hospital for encephalopathy confusion. The daughter had concerns about his ability to care for himself. He was found lying on the floor at home. And then he had infections. He went through below knee amputation. And now he's asking for pain medicines, even when the staff are convinced that he's not in pain. So again, very important in older adults to accurately diagnose. We need family input. Uh, Falls, confusion, memory problems, daytime sleepiness are all other red flags. But there are also other red flags. Next slide. So if they are frequently refilling, which is also seen in adult population, if they are increasing the dose without talking to us, if they are frequently presenting to the emergency department, uh, all these are red flags, even in older adults. Next slide. Again, I've seen many times older adults don't keep these medicines safely, and and then they're often stolen by family members or other friends who are misusing opioids, uh, stealing or borrowing from others. If they're having a lot of disruptive behaviors, then it might be that it's opioid induced psychiatric side effects. And then again, not taking as prescribed. Next slide. Many a times we don't realize that when somebody is asking for more opioids, actually they have opioid induced hyperalgesia, and we should be reducing opioids, not increasing. And we need to learn how to differentiate that from opioid tolerance, opioid withdrawal, and opioid use disorder. Next slide. One specific recommendation I have for all older adults seeking help for chronic pain, opioid use, opioid misuse, opioid use disorder is to routinely do this 4 M's of age-friendly healthcare. So what matters to the first case, he was the counselor for addiction, 77-year-old male. What mattered to him was really not relapsing. What mattered to the second patient in the nursing home was quality of life. She was in such severe pain that she felt that she would rather live less, but live with as less pain as is possible. So, what matters discussions are very important. Again, opioids can cause delirium, they can worsen cognitive impairment, they can increase uh, uh, all kinds of psychiatric effects. So, we need to monitor for that. Mobility is routinely uh, uh, looked on, whether they need help regarding prevention of falls, falls assessment in detail through comprehensive geriatric assessment, routine use of physical therapists, and then again, medications, mainly de-prescribing. Next slide. I'll talk a little bit about treatment, pharmacological interventions, as well as psychosocial. Next slide. So again, psychosocial, we know, same thing in adults, education, 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 motivational interviewing, individual therapy, counseling. The key thing is to realize that there is a lot of ageism. So a lot of people think the older adults will not benefit from individual counseling or group therapy or mutual aid support groups, but that's not true. In fact, I've seen even better outcomes from in older adults. Next slide. So this is where the rubber meets the road. We all need to become better at learning about pharmacological interventions for opioid use disorder and actually doing it, and through collaborative care in complex cases, especially in older adults, getting guidance from geriatricians, geriatric psychiatrists, pharmacists with geriatric expertise. And to me, buprenorphine, skills in prescribing buprenorphine is where all the money is. I've been doing this practice for like 26 years, and my physician assistant has saved more lives than I have in 26 years. And he's been in practice for 6 years because he's become really good at appropriate buprenorphine prescribing for opioid use disorders. Next slide. Again, just a reminder that there are occasional cases in older adults where we may not be able to use buprenorphine or methadone, and we may judiciously use slow release morphine for opioid use disorder. Next slide. Again, these are basics that we can discuss at some point, but buprenorphine is really safe relative to full agonists. And many experts and expert guidelines recommend that as the first line opioid. If you had to give opioid for long-term opioid therapy, there is much less euphoria, so there's less risk of abuse and less risk of overdose relative to full agonists. Again, it's a high-risk medicine in older adults, no question. And again, we need to just become more comfortable learning about buprenorphine and prescribing. Next slide. What about methadone? As Dr. Lisi mentioned, there is risk of drug-drug interactions, QTC prolongation, overdose deaths. So I would say buprenorphine is safer, but what happens if older adults have memory problems and they're living alone? Then maybe naltrexone and long-acting injectable naltrexone might be preferred over buprenorphine or methadone. Next slide. This is where, again, in older adults, engaging the family members, friends, the church community, their spiritual community, shared decision-making. Like in that second case, we were not adamant that we will not go back to Oxy. We need to work with older adults and have some trust. And again, a lot of bias we need to proactively address, both addiction bias and ageism. Next slide. So key takeaways are innovation, innovation, innovation through collaborative care models, telemedicine, manage chronic non-cancer pain without opioids, develop knowledge, skills, and practice, learn to prescribe, monitor, and follow up with buprenorphine. And again, the 4 M's of age-friendly medical care. Next slide. So I'll end with this.
I'm just going to jump in
Yeah,
quickly. I know we have about 5 minutes left
agree.
for our audience. So just wanted to give you that 1 minute mark, if you could,
Yeah.
and
For
then we'll
sure.
have questions and answers.
Yeah. So we have 20 more slides, so take your time to go through them. I wasn't planning to go through them. And I'll just finish reading this. Dr. Atul Gawande, this applies to opioid use disorder in elderly. We are caught in the transition phase. However miserable the old system has been, we are all experts at it, meaning giving opioids for chronic non-cancer pain, not treating or recognizing opioid use disorder, opioid misuse. We know the dance moves with this new way in which we together try to figure out how to face mortality and preserve the fiber of a meaningful life with its loyalties and individuality. We are plodding novices, so we have a lot to learn from each other. We are going through a societal learning curve, one person at a time. Thank you.
Thanks, Doctor. Thank you for your all the great information both you and Dr. Lisi shared. I think really very helpful. Um, I know we only have about 4 minutes, so just some quick questions. Donna, can you speak to about the site that you referenced about how to access prepaid drug mailbox envelopes?
Yes, that site, it's for pharmacies as well as any organizations that prescribe opioids. They can go on that website and order
Yes, what
prepaid
is the
bags.
website? Was it on the slide?
It was on the slide. Yeah, it was on the bottom of
Okay.
the slide.
So, for those of you who are looking for that information, you'll get a copy of the slides by tomorrow, and you can take a look for that information there. And Dr. Desai, you referenced some ebooks. Are they available on a specific website, or
No,
is
you
your
can just email me, but I've also sent a copy to Matt, uh, and he'll put it up on the website along with my slides. The book is Chronic Non-Cancer Pain Management in Elderly.
All right, great. Thanks so much. Um, so just we had some questions for both of you, and I'll go to you. I'll go to you first, Donna, and then Dr. Desai, if you can jump in. What is your thoughts on Adderall prescribing for the aging population? And is there anything to be concerned about in terms of co-prescribing with opioids?
I think, with Adderall, ADHD, it may be blunted a little bit more in older adults, but it can still exist. And so if it's necessary for functioning, then I would say that I would be more cautious, cardiovascular and for cardiovascular effects. But I would say that if it's necessary for their functioning, then it could still be continued. But I would defer to Dr. Desai on this. He might
Yeah,
have seen more
yeah,
case.
same thing, Dr. Lissy. Is it severe? How much is
Mhm.
it functioning? What's the
Right.
comorbidity? What matters to them? And it should be a team decision, including family members. But I would say that for every one person that I would say yes, there are at least nine that I would say the risks are more than benefits.
Dr. Desai, you mentioned family just now, and you mentioned it throughout your presentation about the role of family community. We have a lot of family members of those who are impacted, family members of people who are aging. We also have, community and faith-based representatives on with us. What would you say are some of the challenges that maybe you face um, working with those groups, and what are some strategies to help work with those groups?
Yeah, so the key thing is try and be non-judgmental or be non-judgmental about being judgmental. It's a journey, and the family members are themselves stressed out. So that's when the rest of the community and faith-based community to come in. And then this is a marathon. This is not a sprint.
No, I think that's very helpful. I know we're running out of time. Before I go to both of you for one last comment, I just want to make note that all of the information on how to access continuing education credit is on the screen. Also, I know there was a survey that popped up about a minute ago. We appreciate any of your feedback. So, Dr. Desai, I'm going to go to you first. Last thought or comment.
Well, ageism is a big deal besides the stigma on addiction. So let's be.
Excellent. And Dr. Lisi?
Yes, no, I thank Partnership for Drug Free New Jersey to bring this topic to the forefront. I think this is something that may not be recognized, and I really appreciated Dr. Desai's case about nursing home and long-term care. This is something that is really not recognized in that environment. So that was such a great case to highlight in this forum. Thank you, thank you, Angela, and thank Matt for all
Oh,
his
absolutely. And thank you again to both you, Dr. Desai and Dr. Lisi, for joining us today and sharing all this incredible information. I know Dr. Desai mentioned there's additional slides that he didn't get to. You'll all receive a copy of the full presentations for you to review. And once again, I want to thank all of our attendees for joining us, both new and old, as you continue to search out new information and strategies and best practices to address the opioid crisis. We are making a difference. Um, and I appreciate you all being here and all of the efforts that you make within your community, in particular with this very important population that we were talking about today. I hope that you can join us next month on June 12th as we talk about improving prevention and treatment for opioid use among racial and ethnic minorities. So thank you so much again for being with us, and have a great day.